All right, so welcome everybody to this session of the 2024 Culture of Data Conference. Thank you all for joining us. We're almost at the home stretch, so thank you for staying with us all day yesterday and all day today. My name is Taylor Bostic. I use she, her pronouns, and I'll be moderating today's session. We also have Allison Rosenthal, who will be managing our Zoom and making sure all the tech is running smoothly for today. Everybody is muted upon coming in, but if you have any questions throughout the session, feel free to drop them in the chat. We'll also have a scheduled Q&A session at the end of today's presentation. So at that time, you can also feel free to unmute yourself once we start that session. If you feel comfortable, you can add your pronouns to your Zoom name by clicking the three dots on your video square and by selecting rename. We have one presentation during this session, and they'll present for approximately 25 minutes, and then we'll have 10 minutes scheduled at the end for Q&A. I'm really looking forward to hearing how these technical systems of engagement have been supporting health equity in Colorado, and I hope you all are too. I'll now turn it over to our presenters, Abigail Fisher and Long Tran, to present Engagement, Not Extraction, Community-Centric Data and Design at Colorado's Behavioral Health Administration.
Thank you, Taylor. Hi, everyone. Like Taylor said, my name is Abigail Fisher, and I use she, her pronouns. It is Friday afternoon, and we have 20 people here. I'm so excited, and thanks for being here and making it to the end. We're really pumped to be talking with you today about design, data, and community-centric practices within government technology teams. And we think that this is a really powerful approach for creating equitable government tech and data systems. And just excited to share some case studies and experiences with you today, and hopefully get you excited about implementing these practices at your own workplaces. And one thing we really hope you come away thinking from this presentation is that design and data go together like peanut butter and jelly, and that by adding community to the mix, it's like drinking a cold glass of milk along with that PB&J sandwich. So just said, the community, data, and design, they all go together, and we hope you take that away from this presentation today. A couple of goals we have for this session is to provide a case study on how design and data teams we've worked with have approached this type of community-centric practice. We want to introduce you to some community engagement methods and share some resources so that you can really think about kickstarting this type of team building at your organization today. We have a pretty quick presentation. We'll probably wrap up a little bit before 2 and then use the remaining time for questions and answers. And we know, please feel free to drop chat along the way. I think Taylor will help us to have those chats come off and go to voice at the end of the presentation. So welcome those, but we'll touch on those questions and answers at the end. Just a little bit more about me. Like I said, my name is Abigail Fisher, and I use she, her pronouns. I refer to myself as a civic designer, which I like to say means that I hold space so I can break down bureaucracy so that communities can design for themselves. I'm a queer person who identifies as neurodivergent, and I bring that lived experience into my design practice. And I'm going to turn it over to Long to introduce himself as well.
Hey, everybody. Thank you, Abigail. My name is Long Tran. Pronouns are he, him. And I'm the product manager for Colorado Digital Services. Yeah, so over 15 years experience in the software development industry, working in broadcast media, finance, insurance. This is, however, is my first time in government at any level. So I'm excited to be here and excited to be part of the Colorado Digital Services. I do work with the BHA, the Behavioral Health Administration, and I managed our behavioral data lakehouse, where our goals are to do data analytics, data visualization, data sharing, and data posterity. Back to you, Abigail.
Thanks, Long. And yeah, so Long mentioned that we work for a team called Colorado Digital Service. And so that's a team of civic technology experts that actually sits within the Office for Information Technology for the state of Colorado. And we're civic technology experts across a couple of different disciplines. I myself am a designer. Long represents product, and we also have procurement specialists on the Colorado Digital Service team. And Long also mentioned the Behavioral Health Administration. So our team gets embedded into state agencies to assist with technology modernization efforts. And Long and I are currently embedded within Colorado's Behavioral Health Administration. And BHA's mission, for those that might not be familiar, though I'm sure many folks on this call are, it exists to improve access to and quality of mental health, substance use, and behavioral health care in Colorado. And in the spirit of centering community, as that is sort of the topic of this talk, we wanted to begin by sharing a quote from a member of Colorado's Behavioral Health Task Force, which was actually the group that recommended the creation of the BHA. I'll let y'all read that quote on your own, but want to call out that this person's poor experience accessing behavioral health care in rural settings for her daughter is sadly not unique in Colorado. And I'm sure that's probably familiar to lots of folks on the call if you're following news around behavioral health in Colorado. We bring this quote forward to say that the BHA's charge is to really ensure that residents of Colorado don't experience these types of challenges when looking for receiving or providing care. And we'll talk specifically in our case studies today about data, community-centric practices, and the technology that behavioral health providers have to engage with at the state level. And as I'm sure is not a surprise to any of you, but technology has a big part to play in improving how Coloradans experience better behavioral health care. And today, our state ecosystem in terms of behavioral health technology is a patchwork of disparate and often antiquated legacy systems that aren't really able to accommodate modern interoperability standards. And we see that creating downstream trickle effects, both on people seeking care and behavioral health providers in terms of the efficiency that they're able to access that care, and then the quality of that care when they do arrive at clinics and offices. Our goal really with the Behavioral Health Administration is to create a more cohesive ecosystem of technology and services so that Colorado residents can experience consistent and quality and easy to access behavioral health services, and that behavioral health providers can use their full focus on their clients instead of battling antiquated state technology. And, you know, to do this, we're going to have to do and work in slightly different ways than government is used to. So this might look familiar to y'all. It's something we call sort of static infrastructure, is that traditionally in government, we're building with a build it once for forever mindset. And this method means that user feedback is typically not collected until it's too late. The goals have been established, the thing has been built. And then, you know, folks are forced to use that technology until it literally dies years later because of faltering systems or software that can't meet the standards that government needs to in order to be in legal compliance. But we know that there's a different and better way forward, and that community has a part to play. You know, iterative infrastructure is really where Colorado Digital Service and the BHA is moving our technology stack, ensuring that tech systems are built for change and feedback from the very beginning, which will ultimately save the state money and drastically improve user experience for anybody who's engaging with these systems. I'm going to begin by talking a little bit about how we integrate methodology like co-design and user testing into highly technical technology and data projects. And then I'm going to turn it over to Long, who will talk about how we translate those insights into our technology builds that continue to be tested and refined throughout the life cycle of that product. So begin, I've been using a lot of words like community-centric design and practice. So I want to start by defining a couple of terms. So we're moving forward with shared language, which is so important. So some of y'all might have heard about the spectrum before, but when we talk about design, and specifically in government settings, it can be really helpful to use the at, for, with, by spectrum to evaluate whether our approaches are truly community-centric or how deeply they are community-centric. As I'm sure most of you have experienced in this room, typically government is very top-down, right? Our leadership determines what services and programs are needed based on a variety of pressures. And that leads to the creation of underused products and programs because, you know, sometimes no one asked in the first place if it was really needed. And that sort of environment really defines what designing at a community is, and why designing at a community can be harmful for those communities and also wastes of precious resources. In a more equitable and efficient approach, community is at the center of the design process, and their involvement never goes away throughout the life cycle of a service or a technology. That's really designing with a community. And our approach to design at Colorado Digital Service and the BHA is to always be seeking ways to deepen our power sharing along the spectrum, moving beyond feedback and into true power sharing, where eventually communities are able to lead that design by community, led by community. So design by. An example of this community-centric design approach is the recent work we did at BHA to unpack the administrative burden caused by contractual and legislated reporting requirements. Administrative burden refers to the time, effort, and resources required to comply with state-mandated reporting rules and regulations. And I'm sure folks will know that this burden is often disproportionate for providers that want to accept public government funding for their services. This quote from a research participant exemplifies what the cost of that administrative burden is on Colorado's behavioral health ecosystem. And specifically, this last sentence is such a touchstone for us. We miss out on actually treating the human, we're losing the people, and we're in this field to focus on the human. So that's really what the stakes of administrative burden look like in practice. So to address this, we talked with over 60 individuals across 16 provider organizations to better understand and co-create a solution to these issues. Our design methodology went beyond gathering feedback and instead deeply embedded providers into the research process to inform technical documentation like data dictionaries, longitudinal reporting models, and tech system specification documents. We performed interviews, virtual site visits where we toured provider technology systems like EHRs and client case management systems, and also included broader surveys and feedback cycles to ensure that we had different levels of engagement if providers didn't have enough time to, say, do an hour-long interview with us. One of our major findings was that providers felt like their data went into a black box when they submitted it to the state. Simply a box to check versus anything useful or any useful data they could use to improve their systems or services. The title of this talk is Engagement, Not Extraction, and providers were telling us that their data processes and systems were doing just that, extracting without providing anything in return. And this insight led to one of our key recommendations in the sense that we're moving our data model to a longitudinal structure, moving from singular treatment submissions to data structures and systems that can intake, process, and visualize longitudinal client data so that providers can make more informed organizational decisions and appropriate care plans for their clients and take that full person and all that they bring to the table into account, including other social care services. Far out in the future, a lot of this work, there's lots of work to do around consent and making sure that communities are understanding where and when their data is being used. And to talk more about that, I'm going to turn it over to Long, who will bring a little bit to life about how we're bringing those technology systems to our tech stack.
All right, thank you. Hey, everybody. Yeah, as Abigail mentioned, as part of that administrative burden research, we found gaps in our behavioral health systems. The data governance that was inconsistent. The different fields, similar fields were labeled differently in different systems, and we weren't really able to manage consent. Client data, it was completely siloed, that black box she was talking about, in their respective systems. And our legacy systems, it was locked down pretty tightly so that we could comply with regulations. That created some unexpected consequences, such as providers not having access to their client data. It also restricted the connection between related systems. That resulted in providers having to submit the same data multiple times. No bueno there. So as far as the data protection goes, we would have loved to have just dive right in and fill in those gaps identified in the behavioral health, in the administrative burden research. But there were two main regulations that guide how our agency manages the data collection, storage, and use of client data. The first one that's pretty widely known, that's HIPAA, but the second one, lesser known, is the 42 CFR Part 2. Now that's a federal statute that outlines the requirements around confidentiality of substance use disorder patient record. So it has a lot more restrictions on how we can use that data, share that data, and store that data. And since BHA functions as a steward for highly sensitive data, HIPAA and 42 CFR, they have a huge impact on how we manage our data. And we also receive data in multiple formats, such as client data in electronic health records, service level records for clients that are enrolled in Medicaid. So a lot of different data types we have to manage, a lot of things to consider there. So this slide is really just touching the surface on what it means to be compliant with HIPAA and 42 CFR legal frameworks. As we implement changes from our admin burden research, we also have to be good data stewards, as our agency is responsible for keeping this data highly protected. So next slide here. And then I want to talk a little bit more about our data lakehouse. We create the BHA, we created this data lakehouse to address those gaps found in the administrative burden research project, but it also ensures compliance with HIPAA and 42 CFR. So we adopted this data lakehouse architecture where we store structured and unstructured data in our data lake. And there it can handle various file types, CSV, XML, raw text, even fillable form PDFs. So as the data is moved into our 3-tier data warehouse, that's initially stored in our staging layer, and then it is clean and normalized in this transformation layer. And then it's made available in our presentation layer. That's where the users can use views and dashboards, or they can create their own to perform analytics. Yeah, we've also built connections between connections and direct data shares so that external applications can connect to it. So no more silo data, no more of that black box. So next slide here. Now, as the data lakehouse does address many of the goals found in our administrative burden research, but one of the biggest goals we had was to reduce the paperwork that providers must do. We wanted them to focus on client care instead. So this data collection modernization system will work with providers, it will adjust to their needs throughout its life cycle. And also the way we understand culturally and clinically appropriate care, that's going to evolve over time. So we want to build a system that can adjust as our understanding changes. And as our data modernization efforts create a streamlined data collection process, it will also have the ability to interact with other systems. Providers, they no longer have to ask the same question to clients multiple times, and they only have to submit that data record once. And also we have the ability to scale with consent. As we have more flexible controls around access, we're able to give providers access to their own client data and to view episodes of care for their clients. So a lot of exciting things to come. So what is this? What's next? What does the lakehouse enable us to do? So in addition to reducing that paperwork for providers, lakehouse will also enable us to do a wide array of items. One of those items is performance measurement. Now, Colorado, we're one of 29 states that use performance metrics to guide how we use our funding. And as BHA provides funding for behavioral health services for people of Colorado, we want to make sure we're using our funds wisely. As we implement behavioral health performance metrics based on the data we collected, and to evaluate behavioral health services for all people of Colorado. And the next item here, that's the master patient index record. This will facilitate longitudinal data and enhance episodic reporting. We're able to link multiple records from multiple systems into one record to better facilitate whole person care. And lastly here, data interoperability. We want to allow for different health systems to talk and comprehend data passed to each other. This includes physical health data and behavioral health data to further enrich our master patient index and enrich our whole person care. Yeah. So a lot of exciting things to come at the BHA in both terms of how we want to support our providers in helping the people of Colorado, and the backend technology we'll be using to facilitate the data exchange. So we want to thank you for your time. Thank you for coming and listening to our talk. And here's our contact information. Feel free to email us with any additional questions that we may not have time for today. So now I think we'd like to open up the floor for questions.
Yes, thank you, Abigail and Long, for that presentation. We do have maybe about 20 minutes for questions. So I do encourage anybody at this time, if they have one, to unmute themselves and voice it, or feel free to drop it in the chat.
Oh, I just have a question for you guys. Thanks for that presentation. Yeah, it's really exciting to think that Colorado is getting closer to getting the data warehouse. I know that this has been in talks for a really long time. I guess I'm just wondering in your model, who has access to the data? Like are there state agencies included, or is it primarily like behavioral health and like behavioral health providers?
Yeah, great question. So right now the access, there's a couple of other agencies besides the BHA that has access to our data. But since our data is pretty sensitive data, and we don't want to just share that out with everybody, we do control we do have pretty good restrictions on who has access to it. We also have a lot of security measures like data masking to protect that data once we do share it out. So right now it's a few other agencies and not so much providers at the moment, but we are working on giving them more access to their data and giving them access to like aggregate data so they can have a better understanding of how they're performing based compared to others.
Thanks.
Any additional questions? Well, Abigail and Long, thank you so much for joining us today. I guess that means your presentation was very thorough. So I appreciate you being here. This will be the end of our session, but before people hop off, I just had a few announcements to make. So thank you all for joining and engaging with us. Slides and any additional handouts provided by the speakers will be available on Sketch for people to download. You will receive a conference evaluation form via email after the conference is over, which is oh my, we're at the very last live session for today. So thank you all for being here with us. We do have one more session. It is a walk and learn that you can listen to. The presentation is titled Promoting Health Equity Through Program Evaluation Partnerships. So after that walk and learn, following this session, the conference will officially be over, and you can keep an eye out for that evaluation email that will be sent to you. So I'm sure you've heard this in every session. We encourage you to take that survey. It helps us plan for next year's event, and there's a small incentive of a couple $50 gift cards if you'd like. So thank you so much for supporting CPHA and for joining us in these sessions the past 2 days. We hope you had a great couple of days and connecting with other public health professionals. If you could give our presenters a warm thank you in the chat, that would be amazing. And everybody have a great weekend. Stay warm. It's snowing in my area. So
Stay warm.
thank you,
Thank you, everybody.
everybody.